Thank you.
Hi, Valer.
Hi, ma'am. Hi.
Got it. Got it. My case vandacha?
Ma'am.
என்னோட கேஸ் வந்துட்டா
வாட்ஸ்அப்ல அனுப்பிச்சிருக்கீங்கல மேம் வாட்ஸ்அப்ல அனுப்பிச்சிருக்கீங்கல மேடம்
ஆமா ஆமா
வர மேடம் ஒரே
thank you
Hi ma'am, how are you ma'am?
Fine. Yara ma'am.
Close பண்ணி வைக்கலாம் எப்போ Shall I go? எப்போ வேணுமோ Is the first presenter Dr. Gauri join பண்ண மாதிரி தெரியலப்பா டாக்டர் சரங்கன்
நீங்கள் டயல் செய்த எண்
மேம் எஸ் மேம்
டாக்டர் கௌரி ஜாயின் பண்ணிருக்காங்களாப்பா
இல்ல மேம்
ஓகே the first presenter அவங்க தான் as of
எஸ் மேம் அரவிந்த் டாக்டர் அரவிந்த் இஸ் தேர்
டாக்டர் அரவிந்த் is there fine டாக்டர் பாலமுருகன் அவர் இருக்காரா
இல்ல மேம்
ஓகே we'll see
எல்லாரும் வரணும் இல்ல மலர்
இல்ல madam they'll join there's a little more time they'll join in a few minutes they'll join
wait
good afternoon ma'am
Am I audible, ma'am? I am Dr. Gauri, the presenter. Ma'am, இப்போ voice வந்துருச்சு, ma'am.
Dr. Gauri, are you there?
Yes, ma'am, I am here, ma'am. Am I
Okay.
audible, ma'am?
Yeah, you're very much audible. Okay.
Okay, ma'am. Okay.
Start in 3 minutes.
Okay, ma'am.
Okay, ma'am. Okay, ma'am. Shall I start, ma'am?
No, just wait, ma. Just wait for some time.
Okay, ma'am. Okay, ma'am. Wait. வந்துருங்க. இதுல பேசு.
Okay. Ma'am, a very good afternoon to you all. Shall we start? It's two, and shall we go on with our 34th, welcoming you all to the 34th City Pathology Meet. We have a host of interesting cases, and Chandra madam, are you there? So can we go on with the first, can we start with the first case presentation? Dr. Gauri, you can start.
Okay, ma'am. I'll start. Okay. Good afternoon to all professors and other participants. I am Dr. Gauri, Assistant Professor in Pathology, Government Kilpack Medical College. First of all, I thank our professor and HOD, Dr. Jamila ma'am, for giving this opportunity to present in this meet. So our case history was, it's a 85 years old female presented with lower abdominal pain for 1 month and history of vomiting, fever and bleeding per vaginum on and off present. And she has the following radiological findings. CT abdomen shows bilaterally enlarged ovary and right ovary of size 7.2 cross 5.5 centimeter and left ovary of size 4.8 cross 3.8 centimeter, showing heterogeneous enhancement with hypodense cystic areas are also noted. And she has also had another lesion near the ileocecal junction. It's a heterogeneous enhancing soft tissue density lesion of size 4 cross 2.6 centimeter, causing infiltration of the terminal ileum and leads to luminal narrowing. And CT brain was normal. And perioperatively, they have sent tissue from the left ovary and imprint cytology smears were done. And it shows the cellular smear. The cells were arranged in clusters and also in few singly dispersed cells. And they also arranged in vague acinar forms were also noted. The cells have round to oval nuclei, condensed nuclear chromatin, and have a scanned cytoplasm. So we have given the report as a possibility of small blue round cell tumor to be considered. Following that, we received the patient has underwent staging laparotomy. And we have received a total abdominal hysterectomy with bilateral sarcopharectomy specimen along with infracolicomatectomy and peritoneal samples. So this is a specimen of uterus with cervix of size 6 cross 5 cross 4 centimeter with bilaterally enlarged ovaries of right ovary of size 6 cross 5 cross 4 centimeter and left ovary of size 4.5 cross 4 cross 3.5 centimeter. And external surface of both ovary, the capsule was intact and it shows a vague nodularity on the external surface. And on cut surface, and the cut surface, it shows of both ovary, it shows a solid homogeneous yellow tumor with a gray-brown hemorrhagic spots along with a few tiny cystic areas are also noted in the right ovary. And this is the microscopic pictures from right ovary, shows ovarian parenchyma with a infiltrating neoplasm composed of tumor cells arranged in nest, cords, and trabeculae, and also in irregular islands that are surrounded by a fibrous strome. The individual cells having round to oval nuclei having coarse granular chromatin with a scant cytoplasm. And the pictures, microscopic pictures from left to ovary shows ovarian parenchyma with infiltrating neoplasm having the same pattern of infiltration like nest, cords, and trabeculae, and also with the same nuclear and cytoplasmic features as that of right ovary. And the diagnosis will be and what will be the diagnosis? Am I audible, ma'am?
Yeah, Maya, you're very much audible. There's no.
Other investigations you have done?
No, ma'am. CEA and all serum markers were within normal limits now.
CA 125.
CA 125, CEA. They have done only the 2 markers. And both are within normal limits.
Why that clefting artifact is noted in the
Yes, ma'am.
specimen?
Yes, ma'am. Yes, ma'am.
Is there any other lesion for the patient in anywhere in the body?
No, ma'am. No, ma'am. No other lesions noted.
Okay.
Only the patient came with the chief complaints will be only the abdominal pain, followed by bleeding PV on and off. No other symptoms also.
No other findings.
Was serum ini been done, ma?
Ma'am, not done, ma'am. Not done, ma'am. Not done, ma'am. And we have done immunohistochemical profile also.
Hmm.
Can you show that, ma'am?
Then the diagnosis will pop up.
Anyone wants to offer any diagnosis, preliminary diagnosis? Anyone? I'm Dr. Jamila here.
Yes. Good evening, Jamila.
Any preliminary diagnosis before we give you
Madam?
IST details?
Is it a neuroendocrine carcinoma, ma'am?
Okay, madam.
Granulosa.
DD, one DD neuroendocrine carcinoma.
Okay, madam. Okay.
Yes, ma'am. Yes, ma'am.
Granulosa.
I think Gauri, you can go give the immunohistochemistry.
Okay, ma'am. Okay, ma'am. We also initially with this picture, we also thought of neuroendocrine tumor, and further these are the immunohistochemical markers, and it shows diffuse cytoplasmic positivity for synaptophysin and granular cytoplasmic positivity for chromogranule. And this tumor cells that seems to be negative for inhibin. And the K67 was positive in less than 1% of tumor cells and it's very low proliferative index. And now what will be the diagnosis, ma'am?
So can it be a carcinoid of the ovary?
Yes, ma'am. Yes, ma'am. We also think of carcinoid of the ovary. And we have given us metastatic well-differentiated neuroendocrine tumor.
So is there any primary lesion?
Yes, ma'am. The patient has also had a infiltrative lesion in the ileocecal region of size 4 cross 2.6 centimeter. And we have also suggested biopsy from the site.
Yes.
And
Yeah.
also the bilateral presentation is most common presentation for metastatic tumor. And we have done extensive sampling. We have done extensive sampling from the specimen also again to rule out any associated teratometastasis. So if it is associated with any teratometastasis, so we'll think of as primary ovarian carcinoma. So we have gone through the sample again, and we have done extensive sampling from the bilateral ovarian tumor, and there was no associated teratometastasis was noted.
The
So,
cut
yeah.
surface was yellowish.
Yes, ma'am, yellowish. And no other cystic areas are that of associated dermoid cyst noted grossly.
We call
So, yeah.
cholestromal carcinoma.
Yes. So you have given us metastatic, well-differentiated neuroendocrine tumor.
So the biopsy report, we have to wait.
Madam, we have decided to follow up with the patient to take a biopsy from the sigmoid lesion to confirm that that is the primary and this is the secondary.
Yes.
Yeah.
Okay.
How common is this? How common is this, Dr. Gauri?
Ma'am, both primary and secondary as well as rare. Ma'am, incidence less than 1% for primary, and for metastatic, the secondary is also it is incidence about 2% only, ma'am.
Did the patient any other symptoms of? Did she have any other symptoms?
No, ma'am. The patient didn't notice. They didn't have any other symptoms. We have asked again also.
3 times secretory tumors will be like this only presentation.
Okay.
Could be
Okay.
this.
Okay.
Okay, Dr. Gauri. That
Okay,
was
ma'am.
a nice start. Thank you. Thank you for that interesting case.
For
Okay,
the differential diagnosis, ma'am.
Continue.
Okay, these are the differential diagnoses to be considered. Granulosa cell tumor, septally Leydig cell, Brenner tumor. And the major difference apart from the incidence and age group involved, the most common difference for primary and metastatic tumor is unilateral presentation, almost always associated with primary ovarian carcinoma. And you have to search for associated teratomatous elements. If it is bilateral, almost always it is metastatic and it is not associated with the teratomatous element. The most common primary site for metastatic tumor is distal ileum, followed by cecum, appendix, and stomach also. And gross both will show solid homogeneous gray yellow pattern. If it is primary, you have to search for associated teratomatous element that will present as a cyst with a mural nodule. In case of secondary, the growth pattern will be multinodular in appearance. The size, it may vary 3 to 7 centimeter for primary tumors. In case of metastatic, it may reach up to 30 centimeter. The microscopic findings were most commonly it present with insular pattern, also trabecular, stromal, and mucinous pattern are also noted. The same findings will be noted in metastatic tumors also, but these mucinous glands are very uncommon in case of metastatic neuroendocrine tumor. So the markers are inconclusive. Both primary and secondary will show the positivity for neuroendocrine markers, and CDX2 will be variably positive in both. And it is associated with carcinoid syndrome, like symptoms like diarrhea, flushing, bronchospasm, everything will be seen. Depending upon the pattern also, it will vary. In case of trabecular and stromal carcinoid, the patient may present with chronic constipation due to release of peptide YY. Prognosis wise, it has a better prognosis for primary when compared to secondary. The survival rate will be longer for primary tumors. So depending upon the patterns, the insular pattern and trabecular pattern, this trabecular pattern will simulate the sex cord-like patterns of the sertoli Leydig cell tumor. But in case of trabecular carcinoid, the arrangement of trabeculae will be longer and thicker, and it is arranged in an orderly manner when compared to sertoli Leydig cell tumor. And the next DD is acinar and prominent follicular-like pattern of carcinoid. So both these patterns will be seen in carcinoid, but this acinar spaces of the carcinoid, here the cells will be arranged in an orderly manner around the acinar spaces, where in case of granulosa cell tumor, these acinar spaces will simulate the col-exner bodies of the granulosa cell tumor. The cells will have characteristic grooved nuclei and also the cells arranged haphazardly around the cavities of the col-exner bodies. These are some of the histopathological clues to differentiate. And also the carcinoid have characteristic salt and pepper nature of nuclear features. And another DD is carcinoma with carcinoid with abundant stroma. So this abundant fibrous stroma will simulate the Brenner tumor, fibrous stroma of the Brenner tumor. But in case of Brenner tumor, the epithelial cell nest or of urothelial in nature, and it shows characteristic grooving. So the take-home message is when you are seeing neuroendocrine morphology in a ovary, we have to first differentiate between whether it is primary or secondary. So when it is unilateral presentation and it is associated with teratomatous elements like stromal thyroid follicles like feature, it may be stromal carcinoid, or the most common presentation will be unilateral and associated with teratomatous element. If it is secondary, means it is mostly almost always bilateral. And it is not associated with any teratomatous elements, and grossly it will show a multinodular growth pattern. Okay. Thank you.
Thank you, Dr. Gauri. That was a very interesting case from you, and thank you, Jamila madam, for that interesting case.
Thank you.
If there are can we go on to the next? If there are any questions, or can we go on to the next case? The next case will be Dr. Vasagi from Srihar. Dr. Vasagi has started screen sharing. Yes, welcome.
Good afternoon, ma'am. Is the screen visible, ma'am?
Yeah, your screen is visible and you're audible. You can continue.
Yes. So very good afternoon to my seniors, and due respects to my seniors and my friends. I would like to thank the organizing team for giving me the opportunity in presenting in the 34th City Pathologist Meet. So I'm presenting a case from Sri Chandra Medical College under the title of this image, which will be justified in the subsequent slides. So presenting a 33-year-old female who has presented with abdominal pain for a short duration. And on examination, there was diffuse pain involving the right hypochondrial region and a vague mass palpable, and a past history of hemithyroidectomy done 15 years back. Only that was significant. And the patient was subjected for radiology.
Please kindly.
I think someone has to mute the audio.
Kindly mute your mic, please. You can continue, Dr. Vasagi.
Yes, ma'am. So an ultrasound right adrenal mass has been detected. MRI abdomen showed a T2 hyperintense solid and cystic lesion in the right suprarenal region in the hepatorenal space, measuring 12.5 into 10.4 into 13 centimeters. So radiologically, a lesion located in the suprarenal region raises the possibility of an adrenocortical carcinoma or an adenoma or a pheochromocytoma, the most common. And they tested for the functioning of the lesion by doing DHEAS and cortisol levels, which were within normal limits. So clinically, they thought to be a non-function tumor arising from the adrenal region of the right side. And radiologically, with the size of the lesion, they thought it could be a malignant adrenal mass lesion. So with that history in the clinical and radiology, they proceeded with a core biopsy of this mass lesion. And this is the ultrasound image, so showing a solid and cystic lesion in the suprarenal region on the right side. So this was the core biopsy we received. We received 2 cores, each measuring 1 centimeter approximately. And in the histology, these cores were showing fibrocollagenous tissue. On higher power, few tubule-like structures were noted. And this is one area which was showing a cyst-like lining lined by cuboidal epithelial cells, and the cells were really bland. So with this core biopsy, we couldn't give a definitive diagnosis. We said the tissue is limited, and we asked for an excision for a definitive opinion. So with this core biopsy, we just gave us linear course of fibrous tissue with few tubules. Following this, an excision was planned, and this was the mass in the suprarenal region, which was excised in toto. So this was the picture taken during surgery. This was the portion of liver over here and the bubble segments. And this lesion was removed in toto, and it was not showing any adhesions to the adjacent structures. So this was the gross image, which was showing a globular mass measuring approximately 14 into 13 into 10.5 centimeters, weighing approximately 845 grams. And this external surface was gray white, globular, smooth, and it was well circumscribed, well encapsulated. And cut surface revealed a cystic area of approximately 5%, and there were gelatinous yellowish areas with few gray black and gray reddish areas in the cut surface. So this was the histology, low power view. And in low power, we could see a focus showing a compressed adrenal tissue and a well-defined fibrous capsule and a lesion over here. So this is the picture showing the lesion along with the fibrous capsule and the compressed portion of the adrenal. So this was the lesional bits, which were showing follicles resembling thyroid of varying size and shape, filled with colloid. And there were extensive areas of edema with fibrous tissue. And this is the higher power view on the follicles, which were lined by this bland cuboidal epithelial cells. There were no overt nuclear atypia, no evidence of nuclear features resembling papillary carcinoma of the thyroid. And we extensively sampled the lesion. All were showing thyroid follicles of varying size and shape, filled with colloid, with intervening areas of edema, dense fibrosis, and hyalinization. So with the histological features, the possibilities we thought of were ectopic thyroid tissue in the adrenal gland, a possibility of a primary thyroid malignancy metastatic to the adrenal gland, or the entity, the thyroid follicular like renal cell carcinoma, is a remote possibility. So when we proceeded with immunohistochemical markers, TTF1 and thyroglobulin, which were strongly positive in our case, giving it a thyroid origin. And we asked for extensive clinical and radiological evaluation of the thyroid also. And they proceeded with an FNAC of thyroid, which was showing this picture. There was scant cellularity, having occasional clusters of these thyroid follicular epithelial cells in a background of abundant colloid and few cyst macrophages. And in cytology, it was reported as colloid nodule. So with this clinical and radiological picture mimicking it as malignancy, and in histology, we saw bland thyroid follicular epithelial cells after extensive sampling, and further investigation of the thyroid of FNAC showing colloid nodule, we concluded this case to be an ectopic thyroid tissue in the adrenal gland. And further, thyroid function tests revealed euthyroid status, but there was an elevation in the thyroglobulin levels. And hence it was titled butterflies in the abdomen, that is ectopic thyroid tissue located in the abdominal region. So the learning points from this case was ectopic tissues may present as large mass lesions, which clinically and radiologically can mimic malignancy. And core biopsy may not help in arriving at a diagnosis. So hence, excision is definitely needed for arriving at a definitive diagnosis in these cases. An extensive literature search revealed numerous case reports mentioning ectopic thyroid tissue in the adrenal gland. And out of these case reports, there was one case report where there was a papillary microcarcinoma arising from the ectopic thyroid tissue as well. And all these case reports excluded primary from the thyroid region. So these are the discussion points. When we see an ectopic thyroid tissue in adrenal location, we definitely have to rule out the possibility of thyroid malignancy. And in the tissue, ectopic tissue also, we can proceed with IHC markers like galectin-3, CK19, and HPME, which may help us in excluding a thyroid malignancy. And molecular testing of BRAF, B600, and KRAS may help in a prognostic significance. These are my references. Thank you all.
I have few questions, ma.
Yes, ma'am.
You said she had undergone a thyroidectomy some years back.
Yes, ma'am.
What was the histological report?
That was not retrievable, ma'am, but clinically they thought it should be a multinodular goiter.
There was no report?
No, ma'am, the patient couldn't retrieve the report.
Okay. Was it a total thyroidectomy or only a hemithyroidectomy?
A hemithyroidectomy, ma'am.
So that means there was some remaining thyroid was there.
Yes, ma'am, which was further sampled for cytology, which was showing a colloid nodule.
Cytology was done, it was not operated?
No, ma'am, it was not operated, ma'am. It was only showing a colloid nodule. It was not operated, ma'am.
Any metastatic follicular thyroid lesion will have clear-cut follicles like this.
Yes, ma'am. Yes, ma'am.
Any follicular carcinoma metastasizing to any other organ will not have all your nuclear and other kind of features of malignancy.
Yes,
it will be only a planned thyroid follicle. So how have you ruled out a metastatic thyroid malignancy?
Yes, ma'am. We discussed with
the lobe which is still there.
Yes,
I think that should have been surgically excised.
Yes, ma'am. We suggested the same to the surgical oncologist also, ma'am. They thought it should be a multinodular goiter, and we'll make the patient have a close follow-up. And if there is any suspicion arising in the future, they said they'll definitely operate for the thyroid also.
Did you demonstrate any adrenal tissue in these sections? I have not seen any, you showing any adrenal histology.
Yes, ma'am. There was a tiny focus of this compressed adrenal gland.
Compressed adrenal tissue was there, ma'am.
Yes, ma'am. Compressed adrenal tissue was seen in a focus.
Okay, because you said it is an ectopic. So unless you have the normal organ,
yes,
you cannot an ectopic, right?
Yes, ma'am.
Okay. But anyway, it needs a further clarification on all these issues.
Yes, ma'am. Yes, ma'am.
Extremely rare to have such a big ectopic thyroid, and that too in an adrenal and in the peritoneal region. So,
yes, ma'am. So when I searched in the literature, it was almost only 11 to 12 cases that has been reported as ectopic thyroid tissue in the adrenal region. And all of the reports mentioned that a primary thyroid malignancy has to be ruled out before calling it to be an ectopic tissue in the adrenal region. And this case also, ma'am, the same as you said, that follicular lesion may present as mature follicles when it is metastasizing in a distant site. And hence, follicular carcinoma has to be ruled out before calling it an ectopic tissue. The same was mentioned in the literature also, ma'am. So we discussed in tumor board also, the same case was discussed in tumor board, mentioning that the thyroid has to be kept on check to definitely rule out a possible primary.
Yeah, that is why. That was teaching which we used to teach even the postgraduates.
Yes, ma'am.
Metastatic thyroid, you cannot expect the classical malignant features.
Yes, ma'am. Yes, ma'am.
Looking thyroid follicles. Anyway,
yes,
thank you for the presentation.
Thank you, ma'am.
Thank you, Dr. Vasgi. Did she have only abdomen? She did not. Did she have any family history of thyroid, any malignancy, any genetic history, anything else other than that?
No, ma'am. No significant family history of anything, ma'am.
This huge tumor just showed abdominal pain. That's all. Nothing
yes, ma'am. Only with the abdominal pain she presented.
Okay. Okay, Dr. Vasgi.
Thank you, ma'am.
If there are, can we? If the discussion is over, then we can go on to the next case.
Thank
you. Perfectly nice presentation.
Thank you, ma'am. Thank you.
So the next presenter is Dr. Balamurgan from Stanley Medical College.
Good afternoon, ma'am. Am I audible and visible? I like to Good afternoon, my teachers and seniors. I like to extend my thanks to my professor and head of the department, Dr. Arnalda Madam, and Dr. Sumitra Madam for giving me this opportunity. We want to let the cat out of the bag. So I'm going to present a clinical case scenario. We had a 25-year-old male patient who had been admitted to hospital for upper abdominal pain for 1 week duration. He had a loss of weight of 8 kgs in the past 3 minutes. Previously was investigated for disease, has been diagnosed with the inherited disorder of at 8 years of age, and he was lost to follow for so many years. He is also a chronic alcoholic and smoker. On examination, the patient does not have any interest, but he had non-tender hepatomegaly. So his blood workup was the complete hemogram shows a mild anemia, and his coagulation profile was within normal limits. And coming to the liver function test, he has a mild elevation in alkaline phosphatase level, and his viral markers are negative. And the tumor markers workup revealed an alpha fetoprotein was elevated to 268, and CA 19.9 is 65. So further on imaging or ultrasound, CT and MRI was done on this patient. This imaging of liver revealed multiple grossly dilated intrahepatic biliary radicals. As you can see in the radiology image here, you're able to see multiple grossly dilated, cystically dilated biliary radicals, along with some radio-intense hepatolithiasis, and also a large mass-forming lesion in the right lobe of liver. Instantly, on screening the kidney, the patient has also had multiple cortical cysta. And the portal vein Doppler study is normal, so there is no features of portal hypertension in this patient. So the surgeons, they proceeded to right hepatectomy, and they had done a cholangioduodenostomy. The surgeons always have an urge to cut open the specimen in the theater, and they wanted to know what is inside. So there was a mass bulging out from the posterior aspect of the liver. So what we did cut open specimen. So this is a liver, visible liver measuring 15 cross 11 centimeters. External surface of liver is smooth, and we can able to see a large biliary calculus on the right side, as much as 7 cross 8 centimeters. On further sectioning of the liver, this is the posterior aspect of the gross specimen. You can able to see an exophytic friable mass which is coming out of the posterior surface. Actually, it was contained within the liver substance. Since it was cut open in the theater, you can able to see on the posterior aspect. So on further sectioning, you can able to see some grossly dilated duct-like structure with the intra-abdominal, a large mass is there. So these are parallel cuts of the specimen, which shows numerous cystically dilated and saccular dilatation of the bile ducts. Some of the ducts show thickening of the wall of the ducts, and many of the cystically dilated ducts show intraluminal calculi. You're able to see some pigmented calculi of varying sizes within the grossly dilated bile ducts. So adjacent hepatic parenchyma is bile stain. You can able to see gross dilatation. In one of the sections, you can able to see large, grossly dilated bile duct with a polypoid tumor inside the dilated. So this is the collection of intrahepatic stones, which grossly weigh about 100 grams in total, the stones itself. Any gross diagnosis based on history? So he was earlier diagnosed with Caroli's disease at 8 years of age. So Caroli nothing but gross intrahepatic cystic dilatation of the biliary ducts. Now he is presenting with hepatolithiasis and a liver mass. So we wanted to investigate whether it's a primary liver mass or it's a secondary liver mass. So on microscopy, so you can able to see a grossly distended bile duct, which is cannot be captured fully in the scanner of the microscope, which is centered around the hepatic artery. This is called as a crescent sign. And it's like a single layer of tall columnar cells with adjacent showing a dysplastic epithelium with micropapillary architecture, and sections from the tumor per se show a tumor predominantly arranged in papillary configuration and glandular configuration. You can able to see the fibrovascular core which is running in between. So the papillae are lined by single layer to stratified layers of tall columnar cells with pleomorphic to vesicular nuclei, some showing prominent nucleoli. So can able to see wall invasion. Extensive areas of necrosis were there. This is a picture of intrahepatic calculi with periductal fibrosis. So adjacent hepatic parenchyma, we can able to see large filaments of fibrosis, which is separating the hepatic parenchyma into vague nodules. Again, broadband fibrosis is separating the liver parenchyma into vague nodules. So this is one focus which is showing a ductular reaction, prominent ductular proliferation due to bile duct obstruction. So this is one focus showing multiple profiles of hepatic artery with equal blood vessels. So this mostly shows the dense acute on chronic inflammation centered around the bile ducts. So there are focus showing bile duct with intraluminal neutrophilic microabscesses. And the surrounding stroma shows acute and chronic inflammatory cells. There are foci showing prominent lymph node aggregates with germinal center formation. So there is gross destruction of some bile ducts. So there are foci showing steatosis. So with all these features, being a patient a known case of Caroli's disease, so we resorted to basic pattern of immunohistochemistry. So we had put cytokeratin 7, which is positive in all the tumor cells. Then cytokeratin 19, which is strongly positive in the tumor cells. And we wanted to go to metastatic adenocarcinoma being a male patient. Cytokeratin 20 is negative. So finally, we find it as a known case of Caroli's disease with intrahepatic cholangiocarcinoma, which is intraductal mass forming and periductal infiltrating. So the additional features as shown were hepatolithiasis, fibrosis of the liver, cholangitis, and steatosis. So I looked up on this journal of gastroenterology, which was published in 2021. They had done a systematic review and meta-analysis of all the case reports which was reported last 25 years. So they collected data from 561 patients from 12 studies, and they have found out the incidence of cholangiocarcinoma in a Caroli's disease was just 7%. So most of the patients, they had an instant diagnosis of small tumor in the while doing biopsy. It's not as evident in our case. So whenever there is a high patient, we encounter a patient of Caroli's disease, high suspicion is needed to find out malignancy. Thank you.
So this case is presented for its rare association of Caroli's disease and hepatolithiasis and a huge cholangiocarcinoma. Any questions? Any thoughts?
Very good presentation. Very meticulous presentation. We thought as much the entity, but after seeing the slide presentation, we made it very clear. Very nice.
Thank you.
Hepatolithiasis has a high risk for intrahepatic. Hepatolithiasis has a high risk for intrahepatic cholangiocarcinoma, but the association of Caroli's and the patient has had Caroli's and then hepatolithiasis and cholangiocarcinoma, since it was a rare. So that's why it was presented.
Very nice.
Okay, ma'am. It's okay then. Then can we go on to the next case, ma'am? That is SRM Medical College. Dr. Supriya Varma will be present. Are you there, Dr. Supriya? Dr. Supriya from SRM.
Hello, yes, ma'am. Am I audible?
Yeah. You're audible and you can start screen share.
Yes, ma'am. Yes, ma'am.
Supriya, you can start your
Yeah.
PowerPoint. Screen
Yes,
sharing.
yes, ma'am. Can you see the PowerPoint, ma'am?
No, you're not able to see. It's just your name. Is there some issue, Supriya?
Ma'am, actually, I'm sharing it, but we are not able to make out, but it's not visible to everyone else, ma'am.
Like, can you log out and then again log in? Maybe you need some time. Can we go on to the next
Okay.
presenter and you can present?
Okay, sure, ma'am. Sure, ma'am. We'll just resolve the issue, ma'am.
Just log in and log out. Log in and then come back again. Log out and come back again.
Okay,
can
ma'am.
we have
Okay.
Dr. Arvind presenting that case from the interesting case from Child Health, Institute of Child Health.
Yes, ma'am.
Yeah, Dr. Arvind, you can start screen sharing.
Okay, ma'am. Ma'am, are you able to see the screen, ma'am?
No, not able to.
Ma'am, I'm sharing the screen, ma'am. Am I audible, ma'am?
You're audible, but your PowerPoint is not able to see your PowerPoint.
Madam, has the other person stopped the sharing completely, ma'am? This is Dr. Anand Misara.
Yes, sir.
The previous person who presented, have they given the stop sharing option?
Stop
Because
sharing.
even we couldn't project it the previous time.
1 minute. Okay, sir. You just keep on hold, sir. We'll have
Yes,
this presentation, Edwin Madam's presentation, and then we can come back to your presentation.
Okay, okay.
Ma'am, Edwin, ma'am, are you ready, ma'am?
Valer,
ma'am.
Are you presenting the case?
Yes, ma'am.
Yeah, 1 minute.
Ma'am, you can start your presentation, ma'am.
Screening.
Screen.
I'm not able to see the screen. Varada.
Varde, madam.
But anyway, can everybody's able to see? Hello? Yes. Good afternoon, everyone. Nice to meet everyone on the Zoom meeting. And we are presenting here a 36-year-old female presenting with complaints of chronic pelvic pain. And The radiology gave a right adnexal mass abutting the right tube. Next slide. This is a gross image. We just received a fallopian tube and measuring 5 centimeter with an attached soft tissue mass and measuring 4 into 2.5 into 2 centimeter. The cut surface showed a just central cavity. Next slide. The histopathology, we just took a section from the tubal epithelium, and the wall of the epithelium showed a picture of an endometrial glands in proliferative phase with endometrial stroma, foci of adenomyosis, and hypertrophied myometrium. Next. The histopathology sections. This is the tube which is showing the very attenuated epithelium, not a proper plique is not made out, but the tubal adenomyosis is there. Next slide. This is the cavity that is like the center cavity of the nodule, showing an endometrial glands and stroma with the adenomyosis. Next slide. They highlight high power view of the thing to highlight the endometrial glands with the stroma and adenomyosis and thickened muscular wall. Next slide. Yeah, this is a thickened muscle wall. Can you appreciate it? Next slide. So we just gave a diagnosis of an accessory cavitated uterine mass called as ACUM. And this, next slide. This is to highlight the picture of the specimen sent to us and as well as the normal endometrium, which is highlighted in the greenish paint. Now, in this specimen, you can appreciate the right ovary, left ovary, and then the right ligament of the right round ligament of the right side and left side ligament, and then the nodule, and you can appreciate the myometrium and endometrial cavity of the normal endometrium in this uterus specimen. Next slide. But this, our specimen, we just received only a portion of tube and then the nodule, which was presenting like the with the endometrial cavity and a tube which with the attenuated lining and endometriosis in our case. But the uterus is not dissected, and we have received only the tube and the nodule attached to the round ligament of the right ovarian, right tubal wall. So the discussion goes like this. If an accessory cavitated uterine mass, which is a rare and newly recognized Mullerian anomaly, and accessory cavity which is lined by functional endometrium within an otherwise normal uterine cavity, in contrast to other Mullerian anomalies in which the uterus is malformed. Next. Next. The differentiating factors. When do you call this as an ACUM? The cavitated mass, it should be defined to myometrium. It should be encapsulated, and the histologic organization in the form of a typical uterus ranging from endometrium and then the myometrium. Next. So this can be easily picked up by a initial routine pelvic USG finding. MRI is highly accurate in making the diagnosis. Next, this is the USG pelvis.
Excuse me, ma'am.
What happened?
The others, please kindly mute your mic and then you can talk. Please, it's disturbing.
Oh.
Madam, you can continue.
Is it okay?
Ma'am, Elinary ma'am, you can continue, ma'am.
Yeah, I can continue. The USG pelvis picture has been put in the screen to able to show you the transverse images with well-defined uterus-like mass with central echogenic endometrium in the right adnexa. Both ovaries are seen separately normal. Okay, next slide. So the incidence, the first case of uterine-like mass was reported by Cosetto in 1981, after which 36 cases have been reported in the literature with various terminologies, of which 22 have been reported after 2010, probably due to increased awareness of the entity. Next. So the theories of the development, it could be a congenital anomaly theory, that is a normal incidence, and heterotopias and metaplasias. So the proposed mechanism in this, the accessory mass could be caused by duplication of ductal Mullerian tissue in the critical area at the level of attachment of round ligament, possibly related to gubernaculum dysfunction. Next. So the diagnostic criteria to call an ACUM, it should be an isolated accessory cavitated mass, usually located around the round ligament, under the round ligament, and with the normal uterus, tubes and ovaries, and with MRI, with the suspicion of an entity of a mass, which will be dissected and send it for pathology examination. After a microscopic examination, we can, if you identify the endometrium, glands, and stroma in an accessory cavity, you can call it as ACUM. Sometimes the cavity may contain a chocolate brown colored fluid, and there should not, if the uterus is dissected, you can appreciate if there is no adenomyosis. And in our case, his uterus was all kept in place, except the right tube, and then the adnexal mass was only sent to us. Although there could be tiny focal adenomyosis in the myometrium of the accessory cavity due to increased intracystic pressure. Next slide. The other possible extrauterine sites can be broad ligament, small bowel mesentery, appendix, colon, conus medullaris, uterosacral segment, ligament. Next. So the gross differential diagnosis, the entity closely mimics obstructed cavitated rudimentary horn with uniconvate uterus, and differentiation may be difficult. MRI will show both will have a cavitated mass lined by endometrium with hemorrhagic contents, but contralateral tilt of the uterus, the banana-shaped small uterine cavity, and a single cornua favors obstructed horn. Next slide. Just to differentiate the two entities, we are given this picture. The right one is a obstructed cavitated rudimentary horn with uniconvate uterus, which is not communicated to the uterus. And I just want to sum up these are all the references. And before that, when you call an ACUM, a rare Mullerian anomaly related to dysfunction of gubernaculum is a treatable cause of severe dysmenorrhea in a young female. This is not rare as thought previously, but the entity must come into the minds of clinician and pathologists when they identify a mass in the adnexa with PID dysfunction, dysmenorrhea picture. Is it okay? Have you all any questions from the seniors of the Sarepal madam and gynecologists of our pathologists, gynecopathologists of our community? I just wanted to, are we all accepting my diagnosis?
Ma'am, this is the first time we are hearing this term, ma'am, ACUM.
Yes, ma'am. This is the first time I'm hearing this term.
Yeah, other cases
Very
also
interesting, ma'am.
accessory
Yeah.
immune system, accessory ovaries, accessory spleen, accessory trachea, accessory uterine canal. But we have not heard the term ACUM. And I was very shocked to see this entity and presenting before the pathologist forum, just for everybody to be familiar with. I myself was so excited when I saw the case and referred the literature and to the discussion with the gynecologist. So I want to share my experience to your thing. Last but not, my assistant Dr. Pooja helped me in all this, presenting this case with me.
Very nice, ma'am. Very interesting case, ma'am. Ma'am, most of them are incidental findings, is it, ma'am? In the literature, they have been incidental findings or any specific
No,
clue
the
to
cases
presence?
were presented with pelvic pain and dysmenorrhea. After an ultrasound or an MRI, if I identify a separate mass, definitely
Mass.
they have to be subjected for surgery, and this has to be, since our patient was 36, but generally it is seen incidental or a presentation will be less than 30 in the literature. So I don't think many of us would not have heard this entity at all, except I think Sita Madam, Sarepal, Kanchana, and Raji Madam, everybody.
Did they not make a diagnosis in the radiology, because the cavity is supposed to be in the adjoining the uterus, right? See, I was
Yes.
not there in the initial thing. I was traveling, so I couldn't connect. After I reached my destination, only I connected in the last part of your presentation. So what was the radiologist found out that this was something like an accessory cavity?
Yeah, in our case, actually, the radiologists not very, they have not done because affordability was not there. USG was done. And one more thing, in somebody was doing a PG was doing a dissertation, they have found out one ACUM previously. So with that in mind, they have dissected this mass and sent it to us. After seeing the cavity and then the endometrium like picture, we went to the literature and then traced back and discussed with OGCN and confirmed it.
Okay.
There was a cavity was there. It was like a small cervix like thing was attached to the
uterus
underground ligament. I didn't suspect this one at all. After seeing the slide only, we were able to come to this intent.
Thank you, ma'am. Thank you for that rare and interesting case, ma'am. Thank you. Thank you so much.
Since it is very rare, I thought I want to share it.
No, how do you rule out an endometriosis, Adil? Because endometriosis can occur anywhere, right? If it is near the broad ligament, when you find endometrial gland and the stroma, you can call it endometriosis, no?
No, but the myometrium.
How do you know it is an accessory uterine cavity?
The myometrium there, and it is a specimen which has a cavity for having an endometrium, adenomyosis, endometrial stromal tissue, and then the thickened myometrium is there in the tissue. Apart from that, the patient has got a normal uterus and tubes and ovaries are intact.
So this is more of a radiological diagnosis, and we are confirming the radiological diagnosis.
Yes. Actually, my technician now, sometimes whenever he sees a tube, which thickened tube, he used to call me, Madam, could be a ACUM. Since we have reported one, that much awareness we have created.
Ma'am, Sita, ma'am, anything you want to share, ma'am?
Jamila.
I was not. Ma'am, yes, ma'am, then we can. Thank you, ma'am. Thank you so much, ma'am. Can we go on to the next case, Dr. Supriya?
Yes. Thank you once again, everybody.
Thank you, ma'am. Thank you so much, ma'am. Thank you for that.
Right.
Yes. Good afternoon, ma'am. Am I audible?
Yeah, you're audible and your screen is visible.
Okay.
You
Okay.
can continue.
Thank you, ma'am. Good afternoon to all senior professors and colleagues. I am Dr. Supriya Verma, Assistant Professor, Department of Pathology, SRM Medical College and Hospital, Kattan Kolathur, presenting a case of unusual cause of rectal bleed under the guidance of my reporting team, Dr. Professor C.D. Anand. Many thanks to my HOD, Professor Dr. Jason John Jacob, and for giving me this opportunity to present in such an esteemed forum, and our respected Dean and Professor of Pathology, Dr. A. Sundaram, for his continuous encouragement to present this case today. Coming to the case details, 60 years female presented with bleeding per rectum, loose stools, and pain in the perianal region since past 6 months. Colonoscopy showed a nodular ulcerative growth at 7 o'clock position, 2 centimeters from the anal verge. Biopsy was taken and was sent for histopathological examination. Microscopy showed bits of anal mucosa, showing lamina propria being totally replaced by a sheet of malignant tumor cells. However, as we can see, the intervening mucosal glands were completely benign, with no evidence of dysplasia in the lining epithelium. Coming to high power, the individual tumor cells show marked pleomorphism, round to oval, polygonal to elongated, spindled tumor cells, having high nucleocytoplasmic ratio, markedly hyperchromatic large nuclei with no prominent nucleoli. 4 to 5 mitosis per 10 high power fields along with few atypical mitosis were also noted. This is again a high power view showing the same elongated to spindled cells with round to oval hyperchromatic nuclei and marked pleomorphism. Focal superficial ulceration was also noted, and there was no pigment noted on the H&E sections. So any diagnosis based on the morphology till now?
Possibility of melanoma.
Yes, exactly, ma'am. And actually, okay, I'll go ahead with the case. To confirm the absence of pigment, Mason Fontana was told, and the absence of pigment was confirmed by its negativity for melanin. So based on the microscopic findings on H&E, the provisional diagnosis of poorly differentiated malignant tumor was given, and IHC was advised for exact characterization of tumor and cell of origin. And the following differentials were considered: poorly differentiated carcinoma, neuroendocrine carcinoma, malignant melanoma, amelanotic type, depending upon the location and absence of pigment, GIST or sarcoma, and lymphoma. So these were the initial panel of markers which were asked for in our department: PAN-CK, CK20, synaptophysin, vimentin, S100, and HMB45. PAN-CK and CK20 was negative in the tumor cells and was only positive in the non-neoplastic mucosal glands. Synaptophysin shows diffuse strong positivity. Vimentin also showed diffuse strong positivity. S100 was also diffusely and strongly positive. HMB45 shows strong positivity in around 70% of the tumor cells. So this is a table with the compilation of all the positive and the negative markers. Coming to interpretation, this was our differential diagnosis. Initially, these 5 differential diagnoses we considered on H&E sections. Since PAN-CK and CK20 was negative, so the possibility of poorly differentiated carcinoma was ruled out. Synaptophysin was diffusely positive, but since CK was negative, the possibility of neuroendocrine carcinoma was also ruled out. Vimentin positivity ruled out the possibility of lymphoma. Other markers like S100 positive, HMB45 positive, or ruled out the possibility of GIST bar sarcoma. So the possibility of amelanotic malignant melanoma with neurocrine differentiation was considered. However, to confirm our diagnosis, we actually went for one more specific stain for melanoma, and that is Milan A. Milan A showed strong positivity in 75% of the tumor cells. So this is the final table showing all the ISC markers, positive and negative ones. And the final diagnosis of primary malignant melanoma, amelanotic type, with neuroendocrine differentiation, anal growth was given. Coming to discussion, anorectal melanoma of the anal cavity, especially the primary melanoma, is an uncommon tumor with an aggressive clinical behavior. It constitutes around 0.5 to 4% of malignancies arising in the anorectal region and about 1% of all the melanomas. Anorectum is also the most common location of malignant melanoma after skin and retina, and second most common mucosal melanoma after head and neck region. It presents in 6 to 7 decades of life with the female predisposition, and prognosis is very poor because most of the cases already have nodal and distant metastasis at the time of presentation. Grossly, it presents as a single polypoidal mass, often ulcerated, and clinically many times it is misdiagnosed as being benign hemorrhoids or rectal polyps. Anorectal melanoma originates from the normal melanocytes, which are localized between the dentate line and the anoderm. And point to note here that 80% of these anal melanomas, they lack obvious pigmentation grossly, and up to 20% are histologically amelanotic. 4 microscopic types have been documented: spindle cell, epithelioid, lymphoma-like, and pleomorphic. The divergent differentiation in melanoma is a known phenomenon, and it is defined as development of morphologically, immunohistochemically, and or ultrastructurally recognizable non-melanocytic cell or tissue components, as many pathologists call it a metaplastic change. Apart from this, there can be partial or complete loss of melanocytic markers, or there can be loss of melanin. The right side table shows the types of divergent differentiation which can be seen in malignant melanoma, and it includes fibroblastic, myofibroblastic, Schwannian, perineural, smooth muscle, skeletal muscle, osteocartilaginous, ganglionic, neuroendocrine, as was in this case, and epithelial. And 70% of the literature shows that melanoma with neuroendocrine differentiation is associated with a poorer prognosis. So in our case, there was neuroendocrine differentiation, which was seen immunohistochemically, and there was also loss of melanin. Why this case was put up for discussion today is because of its diagnostic difficulties and potential pitfalls. The first point is because of the non-specificity of symptoms, as it is rectal bleed and loose stools. Many times it is clinically misdiagnosed as benign hemorrhoids or polyps. Even grossly, it presents as nodular or polypoidal mass with ulceration, and then also clinically it is misdiagnosed as hemorrhoids or polyps in that way. And anorectal melanoma has a diverse histomorphology, unlike cutaneous melanomas, where we usually see a very prominent eosinophilic macronucleoli, which is absent in most of the cases of anal melanomas. There is absence of melanin pigment. About 1/3 of the cases of anal melanoma shows no melanin pigment, which adds more to the diagnostic difficulty. And there is frequent aberrant expression of non-melanocytic IHC markers and loss of one or more melanocytic markers, which can also lead to misdiagnosis. These are my references. Thank you so much.
Thank you, Dr. Supriya. Was there any immunosuppression associated with this case? And what about, was there any loco-regional lymph node affection?
Ma'am, there was no immunosuppression in this case, but there was loco-regional metastasis to the obturator and mesenteric lymph nodes. Even there was distant metastasis to lungs and liver. There were nodules in both lungs and liver at the time of diagnosis, when we diagnosed it, ma'am, radiologically.
Even at the time of diagnosis, he presented with metastatic deposits. Okay.
Yes, ma'am. Initially, when we got the biopsy,
Madam, at the time of the biopsy, this is Dr. Anand here. The time of the biopsy, we just got this and with very limited information. And later on, during the tumor board discussion, only then the patient was fully later on worked up. They thought it was probably a ulceration. Probably the first diagnosis they thought was clinician was adenocarcinoma. And later on, they said their full workup was done, PET scan was done, and then only when we were giving the diagnosis, histopathology and IHC was going on, that time they said there was distant metastasis to liver as well as bones as well as lung. So only later on they worked it up when we thought that there is a possibility of the melanoma.
Yes.
So what happened to the lung lesions? Was there any light on the lung lesion? Was any biopsy done and sent again?
No, madam. After the full diagnosis was given, the patient, due to affordability issue, they got, wanted to go to Cancer Institute and do the full workup. So as far as the information we had was they had the medicine, the distant meds. So I think they chose to go to a place where they can do affordable full workup. So as of now, that is the last point of contact we have with the patient.
That was a nice case.
Initially, the problem was once the neuroendocrine first synapto came as positive, there was a small diagnostic hitch to that, was whether it could be still neuroendocrine. Possibility was there, and then because PAN-CK was negative, 100% was negative, then we had to entertain this possibility and see the literature that there is aberrant expression of neuroendocrine or other origins also. So just to make sure, be sure it is definitely melanocytic, we went for melanocytic in addition to HMB-45.
But
so then it turned out.
Nucleoli was not very prominent.
Nucleoli was not there, ma'am. Correct, ma'am. That is what even in the literature says the melanoma in the rectum, rectal region, it doesn't have the classical macronucleoli, eosinophilic macronucleoli. In fact, we saw more of hyperchromatic, large hyperchromatic cells with even micronucleoli we could not make what was.
And the presentation also like the cord-like cells as a cut like a sausages.
Yes, ma'am.
Presentation we were thinking of GIST or a melanotic melanoma was our DD.
Yes.
And prime melanoma, just both are common in the site.
Yes.
Common site. But
that is why we entertained that DD from the beginning because of the site. And in the initial panel itself, we suggested HMB-45 along with the PAN-CK. So the only thing was the neuroendocrine also showing up was the difference here. Neuroendocrine synapto also coming positive, HMB-45 also coming positive. Then we had to reanalyze and work it up again. And then finally we came to the.
What is the incident?
What is the treatment now?
Patient.
The patient is with distant meds. He has been referred outside to Cancer Institute. So we don't have any communication with the patient now. I could talk to the oncologist today morning also.
No, about the incidence of this type of presentation.
Incidence, what they say is it's very rare to have the neuroendocrine, and they say less than 5% or maximum 5 to 10% of the melanoma is presenting with neuroendocrine.
Only the neural crest derivation only made the entity is common.
Yes.
You have to think in terms when we have a picture like
this.
The thing you are wanting to bring out in this issue.
Yes.
Good. Because we never expected the neuroendocrine component at all.
Yes, madam.
So you actually a very good camouflage of the tumor.
Yes.
Thank you.
Thank you.
Sir, can it be just a thought? Can it be could it be a differential diagnosis of PCOMA come here?
PCOMA, we didn't see any clear morphology or that is why, ma'am. That is why HMB-45 when it became positive, we had the PCOMA also on the side, and that is why we went in for melanocytic, an additional marker as projected here, ma'am. So once the HMB45 came positive, then we put melan A also as a specific melanocytic marker. So that is why when we had two markers to support the melanocytic origin, so we went in for that because that will not be positive with PCOMA will not have melan A positive.
No, some HMB45 and melan A, they are also used to confirm the diagnosis.
Yes, sometimes, but we saw that the pleomorphic cells and the morphology and the location.
Okay.
So we went more in for this.
Okay, sir. Thank you, sir.
Okay.
So this is the primary melanoma of the anal region with probably a metastasis to the lung and the.
Yes.
Thank you, sir. Thank you.
Thank you.
Thank you for that.
Just one comment added. Rectal melanoma
Yes,
is
madam.
not that very uncommon, doctor. In fact, I have reported quite a few cases, even in the biopsy material. And
Yes, ma'am.
even in the research. So rectal melanoma is not very
No, we
rare.
just wanted to
Not
tell
very
about
rare.
the neuroendocrine differentiation.
Yeah, that is what
part
I
alone
wanted
is
to
the
say.
rarity.
Yeah. So it is the amelanotic type and the neuroendocrine differentiation makes this tumor a little unique.
Yes, ma'am. That is the reason. That is why we are presenting, because one is the diagnostically the absence of pigment, but still we have that amelanotic in consideration. But when we worked it up, this neuroendocrine strong positivity was one of the reasons why we are presenting as rare.
Very nice. Thank you.
Thank you.
Thank you, sir. Thank you.
Thank you, madam.
Nice discussion. And
Yes.
thank you, Dr. Supriya. And,
Thank you, ma'am. Thank you so much.
And thank you, sir. Thank you. Sundram sir is, I think Sundram sir is, thank you so much, sir. Thank you. And,
He's listening when there. Yeah, he's there.
yeah,
Yeah,
okay.
thanks.
Thank you, Madam.
Yes,
I
sir.
just-
Yes, sir. Thank you, sir. Welcome, sir. Honored you're here, sir. Thank you, sir. Thank you.
Just listening from the beginning. Thank you all.
Yes, sir. Thank you, sir. Thank you so much, sir. So we go on to the next case from Government Tiruvallur Medical College, Dr. Gugan. Dr. Gugan, are you there? Please share your screen.
Yes, ma'am. Ma'am, am I audible, ma'am?
Yeah, you're audible, Dr. Gugan. You can start.
There is a screen visible, ma'am.
Yeah, your screen is visible. You can start. Good afternoon.
Thank you, ma'am. Good afternoon to one and all present here. On behalf of Government Tiruvallur Medical College Hospital, Department of Pathology, I am here to present an interesting case of appendiceal neoplasm. Coming to case history, it was a 70-year-old female admitted with complaints of abdominal pain for 5 days. On examination, her vitals are stable. Abdomen showed right iliac fossa tenderness alone, and it is soft. There was no guarding or rigidity. An additional finding was umbilical thickening. Then the patient proceeded with CT abdomen. Their impression was ruptured mucosal of appendix with soft tissue thickening in umbilical region. And the additional finding is both ovaries appear to be normal. Then patient was proceeded with to exploratory laparotomy and right hemicolectomy. On opening the abdomen, peritoneal cavity showed approximately 200 ml of mucoid material. In this picture, we can notice the unhealthy base of appendix. So they proceeded with right hemicolectomy. Okay, this is a specimen we received in our department. So right hemicolectomy with the portion of ileum, appendix, cecum, then ascending colon and a portion of transverse colon. In this picture, the adjacent mucosa, that is the colonic mucosa, appears to be normal. This is the closer view of appendix, which has been ruptured, and the appendiceal wall is thickened with mucoid material. Coming to microscopy, the appendiceal mucosa has been extensively ulcerated with an infiltrative neoplasm arranged in an irregular glandular and singly scattered glands infiltrating the muscularis layers. This is a closer view. We can see the neoplastic glands infiltrating into the muscularis layer along with pools of mucin. This is the another section showing the infiltrative type of glands. This is the hyper view. We can see the nuclear stratification Individual nuclei shows pleomorphism and hyperchromatism. This is another picture of hyperview depicting the high-grade dysplasia of the nuclei. There was abundant mucinous material along with floating tumor cells. The floating tumor cells have had high-grade dysplastic nuclei. In this picture, the mucoid material seems to invade into the periappendiceal pad of fat. This is the adjacent colonic mucosa, which was unremarkable except for congestion and edema. This is the ileal mucosa. It was also appears normal along with congestion. Okay, this was a gross picture of the umbilical nodule. The cut section showed mucoid material beneath the skin. In microscopy of the umbilical nodule, showed skin with underlying connective tissue showing mucoid material and very occasional neoplastic cells. This is the hyperview. We can see the skin along with mucoid material in the subepithelial region. Okay, coming to the diagnosis. Okay, based on the findings of high-grade dysplastic epithelium along with extracellular mucinous material in the which is perforating through the appendiceal wall, and also the mucinous material is present beneath the skin of umbilical nodule. So we had a diagnosis of mucinous appendiceal adenocarcinoma with Sister Joseph nodule. Our differentials were low-grade appendiceal mucinous neoplasm and high-grade appendiceal mucinous neoplasms. How to differentiate is in low-grade appendiceal mucinous neoplasm, the mucosa shows villous or filiform epithelium, but there is only mild nuclear atypia allowed. There will be only pushing margins along with hyalinization and fibrosis of the appendiceal wall. Okay, this is the picture, book picture showing the villous pattern of mucosa with mild atypia noted in the B picture. There is no infiltration. In this case of low-grade appendiceal mucinous neoplasm, we can see that mucin is perforating through the appendiceal wall, but the mucosa appears to be low-grade. In high-grade appendiceal mucinous neoplasm, the mucosa shows stratification of epithelium. The pattern can be micropapillary and cribriform with pleomorphic and hyperchromatic nuclei. But how to differentiate from adenocarcinoma is this HAMN has only broad pushing margins. There will be no invasion and no desmoplasia. This is the book picture of HAMN. We can see the high-grade dysplastic nuclei, but there is no there is no invasion into the underlying muscularis layers. So the final impression of our case was mucinous adenocarcinoma of appendix, grade 2, that is moderately differentiated grade, with resected margins being free from tumor tissue. The pathological staging was T4A, which is tumor involving the serosa. N0, we identified 2 nodes, but there is no metastatic deposits. And M1C, since the metastasis is to the distant sites, that is the umbilical skin. The review of literature showed there are only 5 similar cases which has been published. That is the combination of both mucinous adenocarcinoma of appendix along with Sister Joseph nodule. The incidence of the primary appendiceal neoplasm comes around only 2%. Among that, the mucinous appendiceal neoplasm is only 0.08%. In our government hospital, that is in Tiruvallur, we received around 230 cases of appendectomy for last 1 year. Incidence in our hospital is 0.2%. Why we presented this case here is the prognosis of mucinous adenocarcinoma is very poor. That is from stage 1 to 3, the 5-year survival rate is around 50 to 80%. But our case was stage 4 disease, which had very less, that is from 10 to 50%. We have to differentiate any cases of mucinous neoplasms from LAMN, HAMN, and adenocarcinoma because LAMN, which is confined to the appendix, has very good prognosis than the HAMN and adenocarcinoma. These are my references. And I would like to acknowledge my dean and my HOD and professor of pathology and my colleagues. And also the patient who had expired 2 weeks post-surgery due to the complications. Thank you, ma'am.
think the moral we have the high grade component is always very abundant in LMN cases in the appendiceal neoplasm. They are more prone for peritoneal metastasis and poor prognosis, isn't it, doctor?
Yes, ma'am. In LAMN, but the mucosa will be of low grade with mild ATPL, ma'am.
Associated with sometimes it just goes with the high grade ones, always will have a peritoneal involvement and poor prognosis reason.
Okay. If there is any peritoneal involvement, any amount of mucinous material present in the peritoneal cavity should be subjected for histopathological examination to rule out the dysplastic nature of the epithelium.
Yes.
Yeah.
Very
Thank you,
nice. You could have done a workup of all the appendix cases, out of which how many presented like this we can give a.
Yes, ma'am. We have took a statistics, ma'am. We have received around 230 cases of appendix in the last 1 year.
Yes.
Among which only this was the first case of mucinous neoplasm we were receiving in our hospital, ma'am.
Yeah, very good, very good.
Thank you, ma'am.
Not many mutation study is not done in this cases.
Mutation studies have not been done here, ma'am. And the patient also has been expired.
If the patient affordability is there, we can just for a
No,
completion.
patient belongs to a rural population in the outskirts of Trivandrum, ma'am.
Correct, correct. Thank you, doctor. Nicely presented.
Thank you, ma'am.
Just one additional, previously there used to be a terminology called mucocele of the appendix.
No more.
The mucocele of the appendix is no longer applicable, and all of them are grouped under the mucinous neoplasms of appendix of different grades. This is just for the sake of the postgraduates and the younger pathologists, because clinicians still don't understand the difference between a mucocele and a mucinous tumor of the appendix. Mucocele is not considered anymore. See, any mucocele of the appendix is actually considered as a misnomer. And we have to call it only a low-grade mucinous neoplasm of the appendix. And pseudomyxoma peritonei and metastatic deposits are quite common in such cases.
Female patients, that too, it confuses with all the entities.
Yeah. Okay, thank you.
Thank you.
Thank you, ma'am.
Thank you, Sita ma'am. Thank you, Elmary ma'am, and thank you, Dr. Gugan. That was a major presentation from Tiruvallur Medical College. That was nice. And thank you, Dr. Sasikala. Thank you so much. And we go on to the next presenter, Dr. Mahita from Mata Medical College. Mahita, Dr. Mahita.
Yes,
yeah.
Ma'am, is my presentation invisible, ma'am?
Oh, your PowerPoint is not visible.
No.
Dr. Mahita?
Yes, ma'am.
You need some time. Can we ask the next presenter? You can log out and then come back again.
Yes, ma'am. Yes, ma'am.
The next presenter for Dr. Archana.
Yes, ma'am. Ma'am, can you see my screen, ma'am? Ma'am, my screen is visible.
Yes, visible.
Oh, okay, sure, ma'am.
No, it is not visible. It was there.
Yes. Good afternoon, everyone, ma'am. So this is a bit of an old case, 4-5 years old case. The patient is a 39-year-old gentleman, and he presented with acute abdominal pain, fever with chills and rigor, and with bowel obstructive symptoms, and bladder movements are normal. And on examination, there were tenderness, and the entire abdomen was rigid. No significant past history. On investigation, he had leukocytosis, low sodium, and X-ray showed gas under diaphragm, and ultrasound showed free fluid in the abdomen. So provisional clinical diagnosis was acute abdomen with peritonitis, probably perforation. So emergency laparotomy was done. And intraoperatively, they found large ileal perforation with ischemic changes. They found feces and pus in the peritoneal cavity. Other organs were normal. So what they did was they removed that diseased portion of the terminal ileum and anastomosed. So what we received was a segment of ileum which showed two large perforations, and the mucosa otherwise also had multiple ileal ulcers. And in both the areas of perforation, there was circumferential wall thickening, like the wall was quite thickened with fleshy, and fibrinous exudate was seen on the surface. So this is the microscopy, as you can see. So this is the ileal wall. There's extensive mucosal ulceration and transmural infiltration by sheets of what looks like small, small to medium or whatever round cells. It's very cellular neoplasm. And on high power, you can see the lamina propria, submucosa, everything is being expanded by what looks like probably lymphoid cells. And this is the high power view. As you can see, the cells are kind of small to medium in size, mildly irregular nuclear contours, some with compact chromatin, some with little open chromatin with indistinct nucleoli, and few mitotic figures and apoptotic debris were noted, and some have kind of clear cytoplasm as well. So the first thing was it kind of looked like lymphoma. So we wanted to know to begin with one T cell and one B cell marker. So this was nicely positive for CD3 and 20 was negative. So the next thing we always want to know is to look at the proliferation index. So it was quite high, around 70 to 80%. So it's some kind of high grade T cell lymphoma. So the next thing that we want to add was adding all the other T cell markers. So 2, 5, 7, as you can see, 5 is completely lost. 2 is very weak expression, almost lost. 7 is nicely positive and 43 is also there. So next we wanted to know the subset. Is it a helper T cell or a cytotoxic T cell? So CD4 was negative and CD8 was diffusely positive. So whenever we do T, we always do NK as well. So 56 was positive in rare cells, but predominantly the cells are negative. Some kind of background staining was there, not sure whether to take it as positive. So we called it as negative only. Only 8 was positive. And then since the cells were intermediate in morphology, we had to rule out lymphoblastic lymphoma. So TDT was also negative. 99 was also done in this case, which is not projected. That is negative. And then 30 is negative. So basically, whether it's some kind of small cell variant of ALCL, so ALK is also negative. So this is the epithelium that was there on top of the tumor. As you can see, the lamina propria is expanded by these atypical cells, as well as you can see marked increase in these intraepithelial lymphocytes. So this is the mucosa that was there just above the tumor. So this is the mucosa that kind of looked grossly normal. So here, if you see the villi crypt ratio looks okay. There may be mild architectural abnormality, rare branching, which is okay. But otherwise, the villi crypt ratio is normal. Not much blunting and all. But here again, you can see the increase in the intraepithelial lymphocytes. So we just wanted to do the IHC on this kind of normal looking, because otherwise the villi looks normal. There's not much expansion. And when we did these intraepithelial lymphocytes also had a very similar immunoprofile with loss of CD2 and CD5, bright CD7 positivity. CD8 is kind of dull, but 4 is completely negative. So IHC wise, 3, 7, and 8 were positive, high proliferation index, and negative for everything, including EBV LMP. So to summarize, it's a monomorphic looking lymphoid cell, small to medium sized. Epitheliotropism was there, increased intraepithelial lymphocytes were there, and they were positive for CD8. So the differentials, so now we know that it is a T cell lymphoma of the intestine, then the differentials that needs to be considered. So I just want to rule in or rule out each entity one by one. So first thing is it enteropathy associated intestinal T cell lymphoma? Previously, it was given as type 1 and type 2, and now they have removed the type 1 and type 2, what used to be called as type 1. Now they have just renamed it as enteropathy associated intestinal T cell lymphoma. So these patients will have history of celiac disease, which which is absent in this patient, and it should show some amount of enteropathy. Celiac disease associated, there is not much villi abnormalities or anything. And the neoplastic cells also won't look so monomorphic. It will be there'll be a lot of pleomorphism. The cells will look little bit larger. And another characteristic feature is the background also show a lot of polymorphous infiltrate, including eosinophils and all. And IHC wise, 4 and 8 will typically be dual negative. 30 little bit of 30 positivity can be seen. Very heterogeneous positivity can be seen. So is it an extranodal NK T cell lymphoma? Again, we did CD56 was negative, but NK T cell quite uncommon in GI tract, but not unheard of. But generally, wherever NK T cell, lot of angio invasion with angio destruction will be there. CD56 positive, typically dual negative, or sometimes CD8 positive, and EBV will be diffusely positive. So is it ALCL, like probably a small cell variant? There also, of course, 30 will be positive, and especially small cell variant will be ALK positive. So anyway, it is negative in this case. So with all this, excluding everything, it kind of fits in what is called as monomorphic, because the cells were monomorphic, epitheliotropic intestinal T cell lymphoma. So this is what was previously called as enteropathy associated intestinal T cell lymphoma type 2. Since there is no association of celiac disease or enteropathy, so it has been taken out as a separate entity, has been renamed as monomorphic epitheliotropic intestinal T cell lymphoma. So this patient, after the diagnosis, they did PET-CT. He had more lesions in proximal jejunum and descending colon, and there was one lesion in the pancreas, no lymphadenopathy. And the patient, the bone marrow biopsy had no involvement. He received 6 cycles of CHOP and 4 cycles of salvage chemotherapy, but unfortunately, as this disease is very aggressive, he succumbed to the disease 1 year after surgery. So just a few words about how this disease has been. In 1978, initially it was just called a celiac disease associated T cell lymphoma. Then in 2008, they divided it into type 1 and type 2, because both had different morphology, different IHC features. And then 2016 is when the next WHO heme lymphoid came. But before that, WHO digestive system came, and then they had called it as an altogether different thing called CD56 positive monomorphic intestinal T cell lymphoma. Then later they have found out that like not necessarily all the cases can be CD56 positive. So they have again renamed it as monomorphic epitheliotropic intestinal T cell lymphoma. And with the present 2022 update, the book is yet to come, but the paper is out. The name is still retained. There is no more change. So this MEI TCL is more common in Asians and typically seen in adults. No history of celiac disease. Most commonly involves jejunum or ileum, and multiple ulcerated lesions will be seen, as seen in our case. So as the name suggests, they are monomorphic, epitheliotropic, increase intraepithelial lymphocytes, but there won't be any change of celiac disease or enteropathy associated changes. They're typically 8 and CD56 positive. In our case, 56 was negative. So then when I was reading this paper, this is a large paper, pooled analysis of multiple institutes. They've done about all T cell lymphomas. So in this EATL type 2, which is been renamed as MEITL, so CD56 was positive in only 73% of the cases. So it can be negative in about quarter of cases. So probably our case probably fits in for a CD56 negative monomorphic epitheliotropic intestinal T cell lymphoma. Thank you, ma'am.
Any thoughts on this case? What was his smear study, and what was the rest of his?
Peripheral smear showed just leukocytosis, ma'am. That too neutrophilic leukocytosis. Other than that, no blasts or any atypical cells in both peripheral smear and marrow. Both were negative, ma'am.
Serum, calcium, hypercalcemia.
That I don't specifically remember, ma'am. I'll have to go back and see I'm not sure if it was done. These investigations were done as an introp, like more like a pre-op thing. He came with acute abdomen, ma'am. So it was done. I don't think it was done, but I will see it again, ma'am.
Retroviral study, retroviral.
A negative, ma'am, because as a pre-op, they have done all viral. It's negative, ma'am. Yes, ma'am. Yeah.
Very nice case, doctor.
Thank you so
Only
much.
thing is it has an aggressive course, right? It's quite high grade. And how is the patient doing? Any
No,
follow-up?
no, ma'am. He succumbed to the disease within a year, ma'am. Yes, ma'am.
But the intraepithelial lymphocytes was there, as you said. That is a point of starting enteropathy associated.
Yes, ma'am. Yes, ma'am.
But that's a good point. We have to be taken into our mind, I think.
Yes, ma'am. To look for whether any enteropathy associated changes or increase in intraepithelial lymphocytes. To look for those subtle changes in the adjacent mucosa. Because most often the mucosa that is overlying the lymphoma will be probably ulcerated or quite expanded. So to look for the such changes in the adjacent epithelium probably will guide us to arrive at the right diagnosis.
He had a history of celiac disease.
He doesn't have history, no, ma'am.
No associated.
Anti-TTG was done after we gave the diagnosis. He was not a known case and it came to be negative, ma'am.
The progression of the case only.
Usually these enteropathy associated, this kind of lymphomas are associated with celiac disease. No, this non-association is quite rare. Is that so?
Yes. Yes, ma'am. That EATL type 1 is always associated, ma'am. This type 2, since there is no association, only they have renamed. This whole rename is because it's not associated with celiac disease, ma'am. These are extremely rare tumors only, ma'am.
Yes. And it can presentation maybe a smoldering one, chronic, and then become acute. It could have been like that in your case.
Yes, ma'am. Maybe.
Acute person.
Thank you.
Anyway.
Thank you. Thank you, ma'am. Thank you, ma'am.
So can we go on to the next presenter, Dr. Sweta? Dr. Sweta Narla from Apollo. Yeah, Dr. Sweta, your screen is visible. Dr. Sweta, are you there?
Ma'am, Dr. Shweta has some issues. She's not able to unmute.
Okay.
Ma'am, am I audible now?
Yeah, you're audible. Dr. Sweta, you're audible.
Okay, ma'am. I'll just share the screen.
Dr. Shweta, your PowerPoint.
I'm not able to share. Probably I'll log out and log in and see, ma'am.
Okay, okay, Dr. Shweta. This is the next. Dr. Mahita, are you ready?
Yes, ma'am. Yes,
Yeah,
ma'am.
please.
Can you start me?
Please. Yeah, your screen is visible. The Pandora's box. Dr. Mahita, you can start.
Thank you, ma'am. Good afternoon, one and all. It gives me immense pleasure to be a part of this 34th City Pathologist Forum. I thank you for giving me this opportunity to present a very short and sweet case about an interception. It's about a 25 years old male who came to the ER with alleged history of slip and fall under the influence of alcohol. The patient had a history of head injury, loss of consciousness, seizures, and ENT bleed. Patient complained of abdominal pain for the past 4 hours that was increasing in intensity, diffuse non-localized, non-radiating, and that did not relieve with analgesics or rest. The patient complained of vomiting 4 episodes, which was non-projectile, non-bilious, not bloodstained, that contained undigested food particles. There was no history of any other injuries elsewhere in the body, no history of burning micturition, constipation, loose stools, or bleeding per rectum. The past history was not significant. The personal history, the patient had a history of mixed diet. He was a known smoker and alcoholic. The family history was also not significant. So the clinicians ended up with a differential diagnosis of acute pancreatitis, liver or spleen injury, or intestinal perforation. On general examination, the patient was conscious, oriented, afebrile, with alcoholic breath. Vitals were normal. Per abdominal examination revealed tense abdomen, diffuse tenderness was present, no warmth. Bowel loops were palpable over the center of the abdomen. Right iliac fossa was empty, gaudingness was present, rigidity was present. On percussion, resonant sound heard over the center of the abdomen, dull note over the right flank region. On auscultation, bowel sounds were heard. Perrectal examination showed a normal sphincter tone, no fissure or fistula, gloves stained with stools. CT abdomen was taken and it showed an ileocolic ileocephalic intersusception up to the hepatic flexure of the colon. The patient was informed about that, and emergency laparotomy and the need for resection and anastomosis was informed. Emergency laparotomy was performed. A big sausage-shaped mass was found in the ascending colon. Enterotomy was done, and multiple loops of gangrenous ileum was found within the ascending colon. Toxic fluid was let out. Gangrenous bowel was resected and iliotransverse anastomosis was made. Temporary ileostomy was created in view of sepsis. This shows the perioperative images. We are able to see some gangrenous segments, and some sausage-shaped segments are also seen. We received the specimen in our department. We received 4 segments of intestine, including 3 segments of ileum that were measuring 70 centimeters, 90 centimeters, and 8 centimeters in length, respectively, and 1 segment of ascending colon measuring 12 centimeters with the attached ileum that was of 2 centimeters in length and appendix of 6 centimeters in length. External surface, the intestinal segments were partly gangrenous and partly viable. On cut surface, the largest segment of ileum showed intersusception that was measuring 1.5 centimeter in length. The appendix appeared unremarkable grossly. We were not able to make out any other lesions grossly, which from representative areas were taken. And this shows the gross picture. On microscopic examination, the sections from small intestine showed intersuscipian and intersusceptum with hemorrhagic infarct, also seen as Peyer's patch hyperplasia, as shown in the images. Sections from the other segments of large and small intestines were partly gangrenous and partly viable. As an incidental finding, we also found Enterobius vermicularis nematode in the lumen of the appendix, as shown in the image. Discussion. We signed out this report as intersusception consistent with the intersusception along with Enterobius vermicularis that was present in the appendix. We want to conclude that this case might be due to Peyer's patch hyperplasia acting as a leading cause for adult intersusception. First of all, what is intersusception? Intersusception is the telescoping of an intestinal segment, which is the intersusceptum, into the lumen of a proximal segment, which is the intersuscipiens. The lead point may be Meckel's diverticulum, polyp, tumor, hematoma, or vascular malformations. It may also be due to Peyer's patch hypertrophy, abdominal TB, foreign body, or adenovirus infections. According to K. Geeta et al., in their study on importance of histopathology of intersusception and evaluation of case of intersusception in infants and children, a 4-year study, they have reported Meckel's diverticulum in 50% of cases, submucosal lymphoid hyperplasia in 32% of cases, inflamed appendix in 13% of cases, and submucosal hematoma in 2%, polyp in 2%, malignant lymphoma in 2% of the cases as the lead point for intersusception. At the end of their study, hypertrophic Peyer's patch was the most common cause for idiopathic intersusception that was seen in ileocolic region. In another study where Suhair et al. Describes intersusception in the pediatric age group due to Peyer's patch hyperplasia secondary to viral infections. In adults, it is an incidental finding. Small bowel intersusception in adults is due to benign tumor like lipoma, leiomyoma, hemangioma, neurofibroma, or it may be due to Meckel's diverticulum, adhesions, adenomatous polyp, and inflammatory lesions. This is another study where Entropius formicularis infestation is associated with small bowel intersusception. And this article is very much similar to our case. Here they are presenting a 20 years old woman, whereas our case is a 25 years old male. Adult intersusception is a very rare entity when compared to the pediatric intersusception. Here again, they are postulating that Entropius formicularis can lead to intersusception through two mechanisms. First one is by causing local inflammation, and the second mechanism is through hyperperistalsis. But this is just a postulation. According to all this review of literature, we want to conclude that in this case, this adult intersusception might be due to either Peyer's patch hypertrophy, or else it can also be due to Entropius formicularis infestation. Thank you.
Thank you, Dr. Mahita. That was a nice case.
Thank you.
Any thoughts about this, or can we go on to the next case? Can we go on to the next presentation? Two presentations from Chettinad. Thank you. That was a super good presentation, Dr. Mahita. And
thank you.
Thank you. And two cases from Chettinad Medical College. Dr. Femila.
Am I audible, ma'am?
Femila, Dr. Femila, you're audible.
Yes, ma'am. I'll share my screen now, ma'am. Good afternoon, everyone.
No. Your screen is not visible.
It will come. I'm just greeting.
Okay.
Good afternoon, everyone.
Yeah.
Now is it visible?
Yes, it is. It is.
Okay. Thanks for giving me the opportunity to present these cases in this meet, and warm greetings on behalf of Chettinad Hospital and Research Institute. The first case discussion is on I think my slideshow is still not on. Are you able to see the slideshow?
You're not on slideshow mode. We are able to see the first slide, 34th City Pathology Meet, Chettinad.
Yes, ma'am. Now is it visible?
Yeah, fine.
Okay, ma'am. So the first case discussion is on two hematology cases which had many similarities. Ma'am, I think
no,
again slide.
No, it is reverted back. Yeah. They'll see on YouTube. Yeah, Femila, you can continue.
Yes,
Dr.
For me, it is. Okay, ma'am. The first case was a 39-year-old female who complained of easy fatigability and dyspnea for the past 3 years and fever for the past 1 week. And history of amenorrhea. And once again, I have some display issues. History of amenorrhea for the past 3 years, and she had taken treatment with 3 doses of injection iron sucrose just before admission, and no history of previous transmission or viral infection. Our second case was a 29-year-old female who was a multi-gravida and who complained of easy fatigability and dyspnea for the past 10 days. Yes, and the history of blood transfusion during childbirth. No history of viral infection was noted. Here we have to note that she is a multi-gravida and she had history of blood transfusion during childbirth. And upon admission, both of them underwent the investigations. RBC count was very low, ranging from 0.38 to 0.85 million per cubic millimeter. And even in the second case, the RBC count was very low. And hemoglobin was again very low, 3.4 to 3.6 in the first case and 4.41 to 4.7 in the second case. Reticulocyte count was high, 7.4% in the first case and 9 in the second case. PT was normal. There was isolated elevation of APTT. Total bilirubin was also increased. Indirect bilirubin was increased. Iron was done in the first case only and it was elevated. Haptoglobin was decreased. Serum globulin was increased in the first case and normal in the second case. Serum uric acid was elevated in the second case. So we, upon a peripheral smear examination, we could see the RBCs were agglutinating, and also we could see the polychromatic cells in the same smear. That is in the first case. In the second case, what we saw was numerous polychromatic cells and spherocytes. I think it is visible for all of you. And we could also see the nucleated RBCs. So with this, we can easily conclude it as a hemolytic anemia and can sign it off, but we didn't want to do that because we really wanted to know what case it could be. So we did some further investigations on that. Ma'am? Ma'am, can't hear you, ma'am.
Yeah, you can continue, Dr. Femila.
If you have any electronic equipment nearby, like a cell phone or something, please switch it off. That may interfere with your transmission.
I switched it off. Sorry for the interruption. I think Yalil ma'am was telling something, that's why I stopped. Okay, I'll
about
continue.
some echoing noise.
Okay, ma'am, I'll continue. So our experience is rarely the whole truth, so we cannot assume things. We wanted to investigate the patient further. Just we wanted to avoid jumping into any diagnosis. So we did some further tests. For example, direct antiglobulin test, we did both in the warm and the cold phases. So we got 4+ positivity in both, and it screening was done at 37 degrees Celsius and 4 degrees Celsius in again at both 37 in 3 phases. That we got a pan agglutination. Pan agglutination means positive in all 3 cell columns, and atypical antibody identification was done with using 11 cell panel at 37 degree, 4 degree, and Liscombe's phase also. In that also we got a pan agglutination, and notably, with this, we can say it can either be auto or alloimmune hemolytic anemia, but we got the autocontrol also is positive. So autocontrol means the patient's serum antibodies are reactive with the patient's own red cell antigens. So it is anyway autoimmune hemolytic anemia. Again, we didn't want to stop at that level. We wanted to investigate the patient further. So the first patient tested negative for ANA and positive for anti-double stranded DNA, ironically. And the case 2 was positive for ANA and negative for anti-double stranded DNA. And SNRNP was negative in the first patient. The rest of the antibodies like SSA, ROLA, Smith antibody, RNP, Jo1 centromere were all negative in the second patient. And complements were quantitated in the first patient, wherein we could see there was a drop in the complements C3 and C4 in the first patient. So the fact we have to accept sometimes in many of our patients, like 2 to 30% of the patients with SLE result negative for anti-double stranded DNA, and a negative ANA test does not rule out the positive anti-double stranded DNA test result. So with this, we can somehow conclude that the patient is SLE patient. So at our level with the blood center and the immunology lab investigations, we still remained blindfolded, but still we sent samples to the referral laboratory for molecular genotyping. So blood group antigen profiling was done by molecular assay. The first case and second case both turned out to be R1 genotype, wherein R1 R2 is the most common genotype, all of us must be knowing. So Duffy was positive, A positive. Kid JKA was positive in the first case, and JKA and JKB was positive in the second case. Kel small k was positive in both the cases. MNS systems M N capital M, capital N, small s in the first case, and capital M, capital M, small s in the second case. So in these among these antibodies, actually these are clinically significant antibodies. If we send to the any immunohematology laboratory, the basic blood grouping antigen profiling will be done for these cases. Actually, if we want to study further, we have to go for sequencing, gene sequencing. So RH antibody is reactive mostly at the warm temperature, but there can be a cold component also. Duffy also is warm reacting, KIT is warm reacting, Kel is warm reacting, and MNS is cold reacting antibody. So some refreshing our ideology or knowledge, the basic knowledge about the autoimmune hemolytic anemia. So warm reacting antibodies optimally react at temperatures of 37 degrees Celsius, and 70% of the AHAs are of warm type. IgG, majority or IgG type, and some can be IgM or IgA or antibodies also. They cause extravascular hemolysis, and broad specificity anti-RH can be of warm type. As I said, there can be a cold component also. They are positive with the polyspecific AHG serum, or more specifically, we use for warm antibody testing a monospecific anti-human globulin serum, and 30% react with anti-C3 with or without concurrent reaction with anti-IgG. So the causes of warm autoimmune hemolytic anemia are primary idiopathic, secondary to autoimmune disorders such as SLE, ulcerative colitis, rheumatoid arthritis, etc. So lymphoproliferative disorders such as CLL, Hodgkin disease, viral infections, neoplastic disorders, etc. So with the peripheral smear of the first case, it was looking more like cold autoimmune hemolytic anemia, isn't it? And the second smear was looking more like warm autoimmune hemolytic anemia, isn't it? But still, in our further investigations, we could see there is a mixed pattern. That is the whole idea of this case discussion. So the findings which are specific to warm autoimmune hemolytic anemia are spherocytes found in the peripheral smear. DAT will be positive with the polyspecific as well as the monospecific anti-IgG in the Coombs phase, and 30% of the cases positive with anti-C3 with or without concurrent positivity with the anti-IgG. Cold reacting antibodies will optimally react at a temperature of less than plus 30 degrees Celsius, ideally at around 4 degrees Celsius. They cause problems when the peripheral circulation cools to this temperature. And 16 to 30% of the autoimmune hemolytic anemias are of cold type. IgM antibody fixes the complement. Cold reacting IgG is ironically present in paroxysmal cold hemoglobinuria. Rarely they can be of the IgG or the IgA type. They cause either intravascular or extravascular hemolysis. The types of antibodies could be either against I or P. P is present in PCH. So the causes of cold autoimmune hemolytic anemia are either primary or due to paroxysmal cold hemoglobinuria, or secondary to infectious diseases, example, mycoplasma pneumoniae. So for whatever cold agglutination cases we had, most of the cases to be positive for mycoplasma pneumoniae, and it can also be positive in infectious mononucleosis, varicella, rubella, lymphoproliferative disorders, and even in HIV. So findings which are specific to cold autoimmune hemolytic anemia is a monospecific anti-C3 positivity, IAT antibody showing characteristic reaction at less than 25 degrees Celsius, cold agglutinin titer more than 1000 at 4 degrees Celsius. In this smear, we get to see RBC agglutination, rouleau formation. And if you see the standing tubes of the anticoagulated blood, visible autoagglutination can be observed as the blood cools to room temperature. There will be false decrease in the RBC count and the hematocrit, false increase in the MCV, MCH, MCHC, and decreased C3 and C4. As we saw in our case also, there was hypocomplementemia. So causes of mixed autoimmune hemolytic anemia, which is actually our case. So it can be primary or secondary to SLE, lymphoma, and HIV. So
connect ma'am.
we diagnosed this case as a mixed autoimmune hemolytic anemia. Again, this is a case of autoimmune hemolytic anemia. So if
No,
we could
no,
have stopped at the
full
beginning-
ஆயிடுச்சுல. Now they cannot add new members.
So depending on the peripheral smear examination, if we had given it as some report, if it's given, we could have diagnosed it as cold autoimmune hemolytic anemia or warm. But actually both the cases turned out to be mixed autoimmune hemolytic anemia. So we need to do further investigations. The proverb "Teedum nandrum pirathara vara" is not always true. So immune hemolytic anemia need not always be auto, and it can be allo too. So this is the first case. If there are no further queries, can I move on to the second case?
Yeah, you can move on to the second case, Dr. Femil.
Okay, ma'am. Our case 2 was a 40-year female who underwent hysterectomy, and incidentally, we found a perineal cyst during surgery. Hysterectomy was done for the treatment of fibroid uterus. So this was the biopsy. It was like a skin biopsy. Underneath, we can see some cyst, small cyst lined by columnar to low cuboidal epithelium, and it was thrown into multiple folds. And then just beneath the epithelium, that is in the immediate subepithelial region, there were capillary sized blood vessels. So again, any vulvovaginal cyst will jump into a conclusion that it could be a Bartholin cyst or a Gardner's duct cyst. So, but this case, it's a spotter only, not so great to discuss, but still it is quite interesting because we don't get to see these case quite often. I'm sorry if it is too simple to discuss. So Bartholin cyst is it is located in the posterolateral inferior third of the vagina, and it is lined by mucinous or low cuboidal or transitional epithelium. But most importantly, it is located in the almost near the vulvar part. So, and Gardner's duct cyst is commonly located in the anterior lateral wall of the vagina. It is located quite higher, and it is a remnant of the mesonephric duct which fails to regress and results in the formation of a Gardner's duct cyst. It is lined by cuboidal to low columnar non-mucinous epithelium. Urothelial cysts are usually situated low in the vagina, and they are close to the urethra due to the urogenital sinus derivation, and it is lined by transitional or squamous epithelium. So is our case fitting with any of these? I don't think so. So did you another case, cyst of canal of Knock, that also I'll discuss. After that, I'll come to the discussion part. It is usually found in the upper edge of the labia majora or the inguinal canal, and it is lined by mesothelium. So our case was not lined by mesothelium, and the location was very classical. It was located in the para-urethral region, just right to the urethra. It was found in the perineal region. So Skin's glands cysts are para-urethral glands. Skin's glands are paraurethral glands, which are 6 to 30 in number. They are located on either side of the urethral meatus. The two largest of these are the Skin's paraurethral glands. They are homologs of the male prostate. They present as an asymptomatic bulging mass with small vessels on the surface, and embryologically they are derived from the urogenital sinus. They are lined by columnar or stratified squamous or transitional epithelium. So our case well fit into the diagnosis of a Skin's gland cyst. Any doubts?
Thank you, Dr. Fanila. That was two interesting cases from Chettinad. Thank you.
Thank you, ma'am.
Thank you. Is Dr. Arvind ready, or because we have reached?
Ma'am, I'll stop sharing.
Yeah, we have crossed 4 o'clock. Arvind ready, or we can take a call on in the next city pathology meet?
Ma'am, even I am there.
Oh.
What is he saying?
Dr. Arvind?
Yes, ma'am. I shared the screen, ma'am. Is it visible, ma'am?
Oh.
Oh, no, it's not visible at all.
Are you able to see the screen, ma'am?
Yeah. Dr. Arvind, yes, continue.
Yes, ma'am. Yes. Good evening to one and all. I'm Dr. Arvind, postgraduate from Madras Medical College. And I have to thank my professor, ma'am, Dr. Chandra ma'am, Dr. Professor Dr. Double ma'am, for this giving this opportunity to present the case here. So it is a spotter case. 4 months old male child presented with intestinal obstruction. The surgeons think that it is a cystic fibrosis. So procedure done was exploratory laparotomy, enterotomy done, evacuation of stools done. The specimen sent was excised enterotomy site for biopsy from the proximal ileum. And this was the histological section from the biopsy site. This is a low power image. And this is a high power image. So can anybody tell the diagnosis?
Yeah, there are no, Dr. Arvind, you can continue.
Okay, ma'am. So it is the KX-late crystals. It is sodium polystyrene sulfonate. It is a potassium binder used to treat hyperkalemia. Commonly used in acute kidney injury patients or with patients with hyperkalemia. In this case, it is a 8-month-old child presenting with acute respiratory distress syndrome and metabolic encephalopathy. In the due course time, the baby developed acute kidney injury with hyperkalemia. For that, the baby was treated with KX-late for 5 days. So the histological images show angulated rhomboid crystals which are basophilic, looking like a fishbone appearance, are present in the mucosa, submucosa, and in the serosa. So these KX-late induced complications are more frequently seen in uremic patients and in post-transplant patients. And the variety of histological tissue reactions include mucosal edema, mucosal ulcerations with granulation tissue, colitis, duodenitis, gastritis, colonic necrosis, inflammatory polyp. Rarely it can present as intestinal obstruction, which was present in our case, and it can mimic as a colonic pseudotumor. So recognition of KX-late crystals in histological sections aids in establishing the correct diagnosis for clinically and endoscopically misleading lesions. Thank you. Thank you, ma'am.
Thank you, Dr. Arvind. Dr. Shweta, are you ready, or can we have your presentation in the next meeting?
Ma'am, I'm ready, ma'am. Can I share it?
Okay, please.
Is my screen visible, ma'am?
Yeah.
Okay. So good afternoon, everybody. This is a small and sweet short case at the end of the evening. So this is actually 2 years old case regarding a neural lesion or a brain lesion. So I've titled this as all proliferating vessels are not hemangiomas. So this is about a boy who's 8 years old who presented with seizures and speech disturbances. So when he was evaluated for the same, MRI brain with contrast revealed a left temporoparietal lesion with calcification and edema. So imaging-wise, a differential diagnosis of PNET, oligodendroglioma, and ganglioglioma were rendered. So when EEG was taken, it showed an epileptiform activity. So the patient underwent surgery and was on anti-epileptics. So actually we received this case as a review slides and blogs for opinion. So the slides which I'll be showing, these are the 2 years old slide. And now the patient had recurred after 1 year post-surgery. So these are the present images where there is a recurrent lesion in the temporoparietal area. So when we review the slides, it showed a lesion which is there predominantly on the cortical surface of the brain. And as we can see, there are numerous tongue-like extensions of the lesional cells within the cortex. So this is another view where it is showing the lesional cells, which is again predominantly seen on the surface, which extension into the cortical area. So close view of the same, this is depicted by the arrow. These are the lesional cells and the background is all the normal brain parenchyma. So the lesional cells are seen in the form of strips and tongue-like protrusions. And as we can see at this part, there's a component of vessels, and it is closely admixed with some form of spindle cell proliferation. So this is a hyper view of the same. So there is admixture of the vessels, as well as there is some kind of spindle cell proliferation. At this magnification, we can see that there is no obvious mitotic activity, there is no necrosis or no microvascular proliferation. This is another view of the same, where it is clear that the background is all brain parenchyma, and there is some kind of tongue-like protrusions of these lesional cells. So this is another part view showing occasional mitotic activity, but there is no obvious necrosis or any atypical mitotic forms. So with this, we saw different areas, and the other areas showed extensive calcification. So the differential diagnosis, what we considered on the histomorphology was because of the presence of the spindle cells and a vascular component, whether it's a meningioma, any angiomatous variant, or whether it is a hemangioma. And the other differentials considered, though it was unlikely, were PNET, schwannoma, glioma. And the other differential what we had was meningoangiomatosis, though it's very uncommon. So we went ahead with immunohistochemistry for further subcategorization. So GFAP highlighted the normal brain parenchyma at the periphery. So these tongue-like protrusions is actually the lesion tissue, which is clearly negative for GFAP, so ruling out a glioma. So these spindle cell areas were positive for Vimentin, so it could be a mesenchymal lesion. Meningioma is one differential because it is a dural based lesion with cortical extension. So we had to do PR and EMA. As we can see, PR is negative and EMA is like faintly positive. So it's unlikely that it is going to be a meningioma. Then schwannoma was another differential. So that is the reason we added S100 and SOX10. S100 is positive in the background cell, whereas the lesional spindle cells are completely negative. The same with SOX10, so it excludes the schwannoma. Hemangioma was a differential, so we did vascular markers CD31 and 34. Admixed blood vessels are positive, but the lesional cells are completely negative for both the markers. And synaptophysin was also negative. CD99 was faint positive, though it's not strong membranous positivity, excluding a PNET. Though uncommon, hemangiopericytoma also has to be ruled out for any vascular lesion. So we did STAT6, that was negative. Ki67 proliferation index was very low. It was around 1 to 2%. So what is the diagnosis now? So it is after excluding all the other entities. So it's finally a meningoangiomatosis. It's an uncommon lesion. So the differential diagnosis, what we considered were meningioma, hemangioma, schwannoma, glioma, PNET, and meningoangiomatosis. So because of the immunohistochemistry pattern, where it was the lesional cells was positive only for Vimentin, it was negative for GFAP, excluding a glioma, negative for PR receptor, excluding a meningioma, negative for vascular marker 31-34, excluding a hemangioma. It was negative for S100 and SOX10, excluding a schwannoma. It was negative for CD99 and synaptophysin, excluding a PNET. So ultimately, it was a meningoangiomatosis. A few words about this lesion. Meningoangiomatosis is a rare lesion which involves predominantly the cortical surface as well as the leptomeninges. It is characterized by proliferation of vessels and there is extensive calcification. There are two types associated. One is a sporadic type which presents usually with seizures. There is another familial type which is associated with neurofibromatosis type 2 and it is asymptomatic. Though uncommon, we have to consider this as one of the differential diagnoses whenever there is a vascular lesion. So the age range has been documented from 11 months to 71 years. So there is a wide age range. The most common sites which were involved were temporal lobe followed by the frontal lobe. So multiple lesions are usually associated with neurofibromatosis type 2. On histology, there are two types which have been described. One is a vascular type and one is a cellular type based on whichever is predominant. There has been three theories in the pathogenesis of this lesion. It could be either a microvascular malformation or it could be a direct invasion of the brain by a meningioma or a meningeal hematoma upon degeneration. So these are the three theories which have been attributed to this pathogenesis, but which one is the correct one is not yet clear. So sporadic cases, there is no association with mutations of NF2, whereas familial cases is associated with NF2 and can be multiple or multifocal. The treatment of choice is surgery. So they have found that after surgery, the seizure-free rates range from 43 to 68%. And they have found that there is no association between the age, location, size of the tumor, duration of the symptoms, and all these did not correlate with the seizure outcome after the surgery. So this boy actually, after the first surgery, he has recurred back. So after the recurrence, since there was no role for radiotherapy and chemotherapy, surgical option was the next line. But unfortunately, the boy has not turned up after the follow-up. So we are yet to see what will happen. We are probably going to call the boy next week. So as of now, there was no role for radiotherapy and chemotherapy. So surgical line of treatment is again the choice of next management. So to conclude, meningoangiomatosis can be either sporadic or familial associated with neurofibromatosis type 2. Even though it's rare, it must be considered in the differential diagnosis of vascular cortical-based lesions. Histomorphology is very important for accurate diagnosis as it is a treatable condition, and immunohistochemistry is done usually only to exclude the other entities, but as such, histomorphology is the only line of diagnostic part. These are my references. Thank you. If there are any doubts, I will be able to take them.
Doctor.
Yes, ma'am.
So in that case, the SFT, one grade of, spectrum of SFT, and intracranial, we thought of angiocentric glioma was our diagnosis. Then later on, the vascular component, after your discussion, I'm thinking it may be a spectrum of SFT, but you said STAT6 also negative.
Yes, ma'am.
But the angiomatosis, you put it in that way, it is a reactive one, you wanted to say?
That's what, ma'am. The theory is what is the reason, whether it is neoplastic or a hamartomatous process. They have postulated 3 theories. So whether it is a hamartomatous process or it's actually a malformation or a neoplasm, it's actually not clear. So that is the reason it could be that they have postulated all these theories.
Being a boy, young boy.
Yes, ma'am.
Very rare, no? We have never heard of this. How is he progressing now? Is he okay after the surgery?
Actually, these slides were from the first surgery 2 years back, which came as a review now. Now, again, since there's a recurrence after 1 year surgery, they
you have done all the markers you have done. All the mesenchymal markers. What made you to put the mesenchymal markers right in the beginning? Because of the
mesenchymal markers, Wyman 10, then 31, 34, S100. Yeah, that's all, ma'am.
Yeah. You were thinking from the beginning in that line, I'm asking.
Okay, ma'am.
Isn't it?
Yes, ma'am.
Because of the cortical and meningeal position.
Yes, ma'am.
Because why I'm asking all this is I'm not able to catch the diagnosis. The entity is rare and the presentation, maybe how you process the progression of the case diagnosis. I just wanted to highlight it.
Yeah, initially, actually, we didn't know what it is. Probably it could be a vascular lesion or any angiomatous meningioma, or it could be SFT. Even we were thinking of these lines. But IHC wise was actually, since all the others were excluded, then we came to the conclusion that it is meningoangiomatosis, ma'am.
Okay.
Anyway, actually speaking, IHC is only to rule out the other entities.
Negative markers.
Yes, ma'am.
So still, this we have to work up in this case, and our references to be made little more, I think.
Okay,
Isn't it? Anyway, Chandra will be able to do some more studies and confirm the diagnosis. Thank you, doctor. Anyway,
Thank you, ma'am.
Thank you.
Cases only to be presented in the forum for certain cases like this, where how we go about is more important. Your way of approach is very good. Thank you, doctor.
Thank you,
Thank
ma'am.
you,
Thank
ma'am.
you, ma'am. Thank you, Dr. Sweta. That was a beautiful case. Thank you.
Thank
So
you.
we close our with a lot of interesting cases on the line presented. So we close our 34th city pathology meet, and this is the first time it has gone beyond 4 o'clock, 4:21. Okay. Anyway, thank you.
Well, we have
Thank
to
you, ma'am.
restrict the numbers, I think.
And the next time we'll restrict it to 8 or 9 cases so that we finish up by 4 o'clock, madam. Next meet, maybe in August.
Thank you. But
Yes,
anyway,
yes.
I
We restrict the
also
cases so that we
feel-
fire. The small is beautiful always. Okay, madam. Okay. Thank you so much. Thank you for all the, thank you the presenters, and thank you, madam, for your contribution, and Sita, madam, and all.
Thank
you.
Thank you, ma'am.
We have to thank you for organizing a wonderful meet.
Thank you, ma'am. Thank you so much, ma'am. Thank you. Thank you. Thank you.
Good.
Thank you, ma'am. Thank you.